Om Swastiastu. We are from Small Group Discussion B1 from PSSKPD 2020 fourth semester. In this occasion, we would like to present our student project with the title Colorectal Carcinoma Screening. My name is Chandra and I will start the presentation. Next. These are the list of members of Small Group Discussion B1. Next. And these are the list of things that we will be presenting today. Next. So first of all, I would like to present about the background. So colorectal carcinoma is the most common type of gastrointestinal malignancy. Colorectal carcinoma may appear either in the colon or rectum. The cause of this disease is multifactorial, including genetic factors, environmental factors such as lifestyle and physical activity, as well as digestive tract inflammatory conditions. Globally, colorectal cancer cases contributed approximately 10% of all cancer cases that occurred in 2020, with the highest incidence rate happening in Southern Europe and the lowest in South Central Asia. Patients with the disease may experience abdominal tenderness, changes in bowel habits, or even none at all at an early stage. Detecting colorectal carcinoma in an earlier and more treatable stage with screening tests may help to reduce the mortality rate of the disease or reducing the incidence by detecting and getting rid of the premalignant precursors polyps to prevent its development. Therefore, the student project will discuss more deeply about the colorectal cancer screening test. And these are the statements of problems. So the first one is, what is the general overview of colorectal cancer screening? And then what is the epidemiology of colorectal cancer? What is the etiology and risk factors of colorectal cancers? What is the pathophysiology and symptoms of colorectal cancers? And what is the screening test and diagnosis of colorectal cancers? Next. These are the purposes to know about the problems that I've mentioned before. Next. And these are the benefits of the study. Next.
Hi, my name is Chandra with last 3 digits to the number 102. The general overview of colorectal cancer. Colorectal cancer has contributed an estimated over 1.9 million of cases and over 900,000 deaths in 2020, ranking it the third in case number behind breast and lung cancer and second in mortality number behind lung cancer. Although both mortality and incidence numbers show a declining trend, it is projected that new cases number may reach 3.2 million by 2040. This number will be affected by a number of factors, include prevention measures, screening, diagnosing, and treatment. From these factors, CRC screening are found to be one of the most important aspects that affect incidence and mortality rate of CRC. It is shown that CRC screening are most cost-saving method compared to no screening and other factors that may affect incidence and mortality rate. However, in general population, rate of colorectal cancer screening still remain at lower than expected number. The screening options for CRC generally include non-invasive and invasive methods. The invasive methods include colonoscopy that are considered the gold standard method that used to detect CRC and precancerous neoplasm. However, due to its invasiveness, high manpower demand, and high overall cost, colonoscopy is not used as a primary screening tool. Instead, fecal immunochemical tests are usually used in primary screening settings. Next.
Okay, my name is Bagus Gede Kinandamas Manuaba, with a 3-digit number is 210. And now I'm going to explain about the epidemiology of the colorectal cancer. Colorectal cancer is the third most frequent cancer and the fourth most common cause of cancer-related death, with over 700,000 fatality each year, trailing only before lungs, livers, and stomach cancer. Next. Colorectal cancer is the second most common cancer in women with 9.2% rate and the third most common cancer in men with a 10% rate. Next. In addition, there are 200,000 cases of colorectal cancer annually, with the major occurrence found in Western country with over 55% of the cases. Next.
So, first of all, my name is Dama, and I would like to explain about etiology and risk factor of colorectal carcinoma. So, actually, the specific cause of most colorectal carcinoma cases is certainly unknown. Generally, colorectal carcinoma starts when normal cell that contains in the colon have a DNA mutation, in which will divide continuously when the cell becomes cancerous. This uncontrollable cell development will be piled up as a tumor. By the time goes on, this cancerous cell can cause damage to the normal tissue that surrounds it or even metastasis. Even though there are no specific causes, but other sources stated that colorectal carcinoma could be present as sporadic around 70%, 20% familial clustering, and inherited syndromes around 10%. There are also several factors that can increase the risk of colorectal carcinoma. Those are getting older, inflammatory bowel disease, personal history, family history, genetic syndrome, or even lifestyle factor. This risk can be lowered by keep doing regular physical activity and keep maintaining body weight within normal range. Thank you.
Hello, my name is Alamanda Candra with 3-digit student ID number 086. Today, I will explain about the pathophysiology of colorectal cancer. Colorectal cancer usually develops through a progression, starting from a pre-malignant stage called adenoma, turns into invasive adenocarcinoma. The progression happened because of the accumulation of genetic mutation, either acquired or sporadic, accounts for 95%, inherited 5%, and other underlying disease such as inflammatory bowel disease accounts for about 1%. The sporadic cause of colorectal cancer divides into three main causes based on molecular pathways. The first one is chromosomal instability, second one is deficiency of DNA mismatch repair or DMMR, and the last one is CpG abnormal methylation of DNA. So the first one is chromosomal instability pathway caused by a mutation that controls tumor suppressor gene. The alteration causes instability of the tumor suppressor gene equilibrium. Therefore, tumors are able to develop into cancer over time. Second, mutations that alter DNA mismatch repair or DMMR, known as high-frequency microsatellite instability or HMSI, happen as a consequence of recurrent error on genome arrangement. Variants of somatic mutation in sporadic oncogene, respectively RAS oncogene, such as HRAS, KRAS, and NRAS, implicated in colorectal cancer. 50% cases of sporadic colorectal cancer caused by KRAS oncogene. So the last one is epigenetic events play a big role in development of malignancy cells. CpG abnormal methylation of DNA could switch off the tumor suppressor genes, causing abnormal cells to grow and develop malignant cells. Another way to inactivate tumor suppressor genes is through loss of heterozygosity or allelic loss in the long arm of chromosome 18 or 18q. Also, resistance to apoptosis driven by the tumor suppressor genes due to the deletions and mutations in the short arm of chromosome 17 or 17q. The next one will be continued by my friend. Thank you.
So thank you for the opportunity. My name is Amadeus Fernandito Leksana, and I will explain about the hereditary pathophysiology of colorectal cancer, in which hereditary colorectal cancer is subdivided into with or without colon polyps. The colon polyps, what are familial adenomatous polyposis, is an autosomal dominant hereditary disease that causes mutations in adenomatous polyposis coli, or APC, which accounts for approximately 1% of all colorectal cancer cases. And the next one is hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, is also an autosomal dominant hereditary disease that has mutations that alters the MMR gene, or especially MLH1, in which this type accounts for 60% of all colon cancer cases. Okay, and then we continue about the inflammatory bowel disease as the pathophysiology of colorectal cancer. So the development of colorectal cancer through inflammatory bowel disease such as Crohn's disease or ulcerative colitis also exist. Chronic inflammation that occurs plays a role in development of colorectal cancer. There are molecular changes in the colon while it is inflamed, including tumor necrosis factor, interleukins, cytokines, and chemokines. And then next one is about the signs and symptoms of colorectal cancer. So it is stated that the early stage of colorectal cancer signs and symptoms is not specific, but mostly in most cases, the early form of symptoms include fatigue and weight loss. More specifically, patients under 50 years old are most likely to present non-specific symptoms that can increase the likelihood of an emergency diagnosis rather than those in age of 60 until 69. Other clinical manifestations of colorectal cancer are iron deficiency anemia, rectal bleeding, abdominal pain, change in bowel habits, obstruction of perforation, and weakness. Although late stages of colorectal cancer can be shown as abdominal tenderness, palpable abdominal mass, hepatomegaly, and also ascites. Okay, that's all from me. Next one will be presented by my friend.
Thank you, Amadeus. Now, my name is Bertrand Wijaya. Now, moving on to the screening test of colorectal carcinoma. There are several methods of screening colorectal carcinoma. First is computed tomography colonography, or CTC. CTC is relatively recent colorectal screening test that has been validated in both clinical trial and clinical practice settings for initial screening. CTC is a non-invasive imaging examination of the large intestine that produces three-dimensional images of the inside of the colon and rectum using X-ray and CT scan. CTC can be performed relatively fast, and the risk of severe complication from the test, including the bowel preparation, is low and likely lower than with colonoscopy. However, due to isolated tiny lesion or polyps that are less than 5 mm, being missed with CT colonography, colonoscopy is still required to remove them or properly investigate the area. Next. The second one is flexible sigmoidoscopy, or FS. FS is a screening method that involves inserting a flexible lighted tube which into the rectum and lower part of colon to examine for polyps, cancer, and other abnormalities and removing them. Although FS has a near perfect sensitivity for viewing and detecting distal colorectal neoplasm, it can only indirectly detect proximal neoplasm if colonoscopy is performed afterward. FS has a 5-year interval or a 10-year interval, but is accompanied by fecal immunochemical test, or FIT, every year. This procedure typically doesn't require full bowel preparation or sedation. That's all for me. Thank you.
Okay, my name is Devi Savita, and I want to explain the stool DNA test. This procedure aims to identify DNA change in stool samples, in which if abnormal DNA conditions are found, there is a possibility of developing colon cancer or polyps. This test is also useful for detecting hidden blood in the stool, which can also indicate the presence of cancer. In the test result is positive, further procedures such as colonoscopy are usually required to examine the inside of the large intestine in cases of polyps and cancer. This procedure has several advantages, namely in the form of easy preparation, and this procedure will not interfere with daily activities, but it's less accurate than colonoscopy. Next. Okay, this is the colonoscopy. The colonoscopy procedure requires consultation to look for contraindications and reduce complications. Before undergoing the procedure, usually doctors will ask to empty the colon first by some optional ways, including a special diet, taking laxatives, and use enemas. Colonoscopy can cause a number of complications or side effects. Immediately go to the doctor if you experience complaints after undergoing a colonoscopy procedure, such as high fever, severe abdominal pain, and bleeding from the anus. Next.
My name is Widya Amritha, and I will continue the presentations. So another screening test for this carcinoma is GFOBT and also FIT. So the first one is GFOBT. The Goyat-based test or GFOBT is a test that uses the heme portion of hemoglobin to detect the presence of pseudoperoxidase activity with hydrogen peroxidase oxidizing guaiac. Both tests with high and low sensitivity are prone to getting false positive results as it is influenced by the presence of food ingredients in the feces, such as red meat or the peroxide content in ingested vegetables and fruits, drugs such as NSAIDs that can cause digestive tract bleeding, or chemicals that come out following the feces. GFOBT test results can also produce false negative due to antioxidants contained in fruits, vegetables, or vitamin C consumption. Next. So the second one is FIT, or the fecal immunochemical test, is a test used to detect the globin component in human hemoglobin, either intact hemoglobin or its degradation products using selective antibodies. The difference between FIT and GFOBT is in the use of specific antibodies and the detection of globin, which is degraded by enzymes in the upper gastrointestinal tract. FIT test has advantages such as higher sensitivity than GFOBT, and a positive result will not be affected by bleeding in the gastrointestinal tract, especially the upper gastrointestinal tract, and there is no need for food or drug restriction. FIT also has disadvantages such as the need for repeated testing because it has a lower specificity. Next. Apart from the differences in the advantages and disadvantages of the two tests, there are similarities between these tests. First, both of the tests can be easily performed at home by simply taking a small portion of fecal by the time to defecate. Second, these two tests are lack of adherence to screening at annual interval and less effective for detecting advanced adenomas. And last, both tests are cheaper than the structural and MDS DNA examination and also need a colonoscopy as a follow-up if the test results is positive. That's all from me. Thank you. Next.
Hello, my name is Pratama. I will continue the presentation. In this section, I will cover about diagnosis of colorectal carcinoma. So when there is a patient with suspicion of colorectal carcinoma, the initial imaging that can be done to confirm or exclude the diagnosis is by endoscopy or colonoscopy. To be able to recommend this examination, several clinical manifestations that can be observed from the patient that lead to suspicion of colorectal carcinoma, such as change in bowel habit, change in stool characteristic, abdominal pain, there is lump or mass in the abdominal area, and systemic symptom. Next. When the lesion image from colonoscopy suggests cancer, patient is recommended to undergo a biopsy for diagnosis, except in patients with contraindications such as bleeding disorder. After establishing the diagnosis, Thomas staging was performed in colorectal carcinoma patient by suggesting contrast agents, computer tomography on chest, abdomen, and pelvis, except in patient with contraindication. To prevent recurrence of the tumor, patient is recommended to perform an MRI examination, which also can be used to determine tumor staging in patient with complication. Are my presentation. Thank you, and next.
Hello. Now my name is Stevanus and Surya, with last 3-digit number is 115. So I will explain the conclusion of our student project. Now, the number one is colorectal carcinoma, or CRC, is the most common type of gastrointestinal malignancy and start to develop when there is denervation in the colon normal cells. When there are several causes that contribute to the development of the cancer condition, namely the accumulation of genetic mutation, sporadic or inherited syndromes, and underlying disease such as IBD or inflammatory bowel disease. Protein cause of CRC can divide into three main causes based on molecular pathway: chromosomal instability, deficiency of DNA mismatch repair or DMMR, and CBG, abnormal methylation of DNA. Hereditary colorectal cancer subdivided into with polyp or adenomatous polyposis coli, or without colon polyps, such as Lynch syndrome. The development of CRC through inflammatory bowel disease or IBD cannot be separated from the role of chronic inflammation. CRC is the third most frequent cancer and the fourth most common cause of cancer-related death. So, the screening are the most important aspect that affect CRC incidence and mortality rate. There are several screening methods that can be done to confirm or exclude the diagnosis of CRC, such as endoscopy, colonoscopy, CTC or computed tomography colonography, stool DNA test, FOBT, such as FOBT and FIT or IFOBT, FS or flexible sigmoidoscopy. Furthermore, the staging of CRC can be known by conducting contrast enhanced CT scan examination on patient with non-complication and MRI examination on patient with complication. Although colonoscopy is often performed for initial imaging, it can be also used to properly investigate the area of cancer after the use of other CRC screening method. Each method used for CRC screening has advantage and disadvantage. Indicate that it is necessary to have a discussion between health professional and CRC patient in determining the method to be used. So this is our reference for this student project. Okay, that's all from us. Now I will close this presentation with Paramasanti, Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Shalom Budaya dan salam sejahtera bagi kita semua.